Hi, I am Dr. Amitabh Banerjee. I am an epidemiologist and author of this book, COVID-19 Pandemic, A Third Eye. And today we come to the end of the reading of this book. We are at the last chapter, chapter 24. In this chapter, I have tried to summarize how the marathon evolved over 2 years. And from data, I have demonstrated that whatever differences were among the continents, among the different countries in the West, among Africa and Asian countries, the gap remained throughout the 2 years of the pandemic in spite of different coverage of vaccination, different lockdowns all over the world, except for few countries. And whatever started in the marathon, the gaps remained constant. Africa had the least vaccination coverage, but the least cases. Western countries had the maximum vaccination coverage. They are still struggling with the cases. So the any amount of intervention hardly had any impact. So as way of all pandemics, the pandemic ran its course and settled depending on the age profile and on the demography and the health of population, as illustrated by the obesity. Obesity is a surrogate marker of general health, and the highly obese countries of the West and some in Africa had high impact of COVID. So this is what I wanted to sum up in this last chapter. And one of the favorite ways I teach epidemiology to my students is by comparing it with chess. The title, in fact, the title of this chapter is the COVID-19 chess game. Are we seeing all the pieces and their combinations on the board? Like in the game of chess, amateur sees only one piece, whereas the professional or grandmaster sees all the pieces and their combinations on the board, which matters more in how the game evolves. So similarly, in a communicable disease pandemic, we have to not only see the virus, we have to consider the other pieces, means the different demographics in different continents, then different, say, health status as marked by obesity, then the population densities, the living conditions, the occupational conditions, the how many young, how many old. So all this will play out, the same virus will play out differently according to this. And during the pandemic, there were frequent lockdowns, and India had also number of lockdowns. There were also the colleges were closed, including medical institutions were closed for almost 2 years. There were online classes, but and I used to go to my department as an essential worker. There was, and I was the head also, but I just went, and there were some study students, some bold students. He used to come and meet me, and I used to teach them epidemiology in this during the lockdowns by playing chess with them. So I'll just share one clip here. I was just teaching my students epidemiology by getting the by giving the analogy of chess, that how to in epidemiology can be as fascinating as chess, and the amateur can make as many mistakes in pandemic control as a amateur can chess player makes it. Yeah, so this is I just wanted to I have compared it with chess. So one of my, while the clinician sees only one piece at a time, like a chess amateur, the clinician sees one piece at a time. The epidemiologist sees all the pieces and their combinations, which is essential to tackle public health problems. So unfortunately, what happens, the epidemiologists and public health people are in the background. And during this pandemic, most of the policies were driven by the clinicians who almost reached a celebrity status. One of my favorite methods of teaching epidemiology is to compare this fascinating field with the game of chess. While a clinician treating individual patients sees a disease problem in piecemeal, and epidemiologist sees the big picture. In chess, the beginner gets fascinated with the queen and neglect the other pieces. A good player sees all the chess pieces and also the combination of the pieces with each other. A novice who focuses only on the queen loses easily to an experienced player. In chess, seeing one's own piece as well as the opponent pieces and their relationships to each other is important to win. The COVID-19 virus was the queen on the chessboard for the past 2 years. Self-styled experts like novice players had their vision firmly focused on it, oblivious to other pieces and their combinations on the chessboard on which the COVID-19 chess game continued to be played. From the early phase itself, that is from May 2020, I have given the tables here in this chapter. Black, represented by the Asian and African countries, were winning. This lead continues throughout the pandemic. As I said earlier, because of the younger population, leaner population, overcrowded, the pandemic settled faster in Asia and Africa. And this difference persisted throughout the pandemic. A rapid look at the data showing deaths per million population on 3rd May 2020 and on 12th December 2020, after 1.5 years, from a sample of Western, Asian, and African countries will make this apparent. I have illustrated this in the tables that what gap was there early in the pandemic, it persisted 1.5 years, 2 years into the pandemic in spite of different resources, different interventions, different levels of vaccinations, particularly the lowest rate of vaccination in African countries stand out, 5 to 10%. And in spite of that, they had the lowest impact of COVID. And in Africa also, there were countries like South Africa, which had a higher obesity. So it had a higher mortality among the African countries, in spite of a higher vaccination, relatively higher vaccination in the African countries. Western countries have better hygiene and sanitation with much lower population density than most Asian and African countries. Still, they had the highest impact. Most African and South Asian countries have very high population densities with a large part of the population staying in slums where physical distancing and hand washing, the measures promoted to control spread of COVID-19, is just not feasible. Also, the black side of the board has many times less vaccination cover than the white. So I have just made it a chessboard. The western is the white and this is the black. And compared the chessboard on both sides, that in spite of and how these differences played out. The same pattern can be observed in almost all the countries in Africa and South Asia shown in the table. Western countries which can indulge in the privilege of physical distancing and frequent hand washing and with much higher vaccination coverage are throughout the pandemic having many more times more fatalities than the COVID-19, than the crowded and unhygienic populations of South Asia, African countries with very low vaccination coverage. What did we miss? What could be the reason for this? The table, just eyeballing the data, I have anybody interested, this is in the book, and those who don't want to buy the book can also see it in a column in National Herald. This chapter, all these chapters are taken from National Herald. You can just type my name, Amitabh Banerjee, and then National Herald, and you will get all my columns there. What did we miss? Why we kept insisting on one size fits all? Obviously, something was very different on the white and black side of the chessboard. Let us look at the other pieces on the board. As will be seen, striking from the tables, the Western countries have much higher median age. Age was a major factor, and much higher levels of obesity as measured by BMI compared to the Asian and African countries. Older age is associated with higher fatality from COVID-19. So is obesity. It compromises lung function and also is a surrogate marker for other comorbidities such as hypertension and diabetes. It seems that even a little higher prevalence of obesity increases mortality from COVID-19 among African countries. Egypt and South Africa are having higher obesity rates and also higher mortality among African countries from COVID-19, albeit far lower than the Western countries. The experience of two outliers, Japan and Brazil, illustrates it very well. Japan has high median age, higher than most Western countries. However, this disadvantage is offset by lower rate of overweight compared to the West. Brazil, on the other hand, has younger population but higher proportion of overweight people. Japan, in spite of higher age, has much lower deaths from COVID-19 compared to Brazil and most Western countries, which indicates that obesity is a major risk factor of adverse outcome from COVID-19. Some have also suggested that past infections with other coronaviruses, because there are other four families of coronaviruses already circulating, likely in overcrowded living conditions, may offer cross immunity against COVID-19. This has to be confirmed by proper studies. Eyeballing the data in the table suggests that the percentage of population fully vaccinated also does not correlate with death rates from COVID-19 at the country level. This should be cause for concern as the world is single-mindedly pursuing the target of universally mass coverage at astronomical cost. Not only this pandemic is already over, at least in Asian and African countries, but we have to again be cautious in future alarms of pandemics. Again, we may repeat the same mistakes. It is possible that, and now there are emerging concerns about the adverse effects of vaccine also. So that also one has to keep in mind. Natural forces, these pandemics are natural forces. It is possible that factors like lower age of population, lower prevalence of overweight, and past infections with other coronavirus may be acting in combination, like weaker chest species. Sometimes these weaker species also get together and can trap the queen. To trap the COVID-19 queen on the black side of the chessboard. That is three things: younger age, less obesity, and cross infection with other coronaviruses may slow down the virus on the African and Asian continents. A study done by researchers of Harvard University and published in the European Journal of Epidemiology is also sobering. This paper reports that there was no impact of mass vaccination on COVID-19 incidence across 68 countries and 2947 US counties. Studies have also established it, peer-reviewed studies. The take-home message is that the epidemiological approach should see all the factors and their combination across different countries and regions to cope with the present and future pandemics. So here we end this chapter and this book also. And I have only covered some of the columns in this book. And though this book reading of COVID-19 ends here, I will be commenting on the other columns also. So you may keep an eye on this YouTube channel. I will be commenting on the other columns and then include those columns also in the playlist of the COVID-19 pandemic, a third eye, so that you may just have a look, which is also a good preparation for any future pandemics instead of panic and chaos as occurred in this pandemic. So that's all. Thank you and goodbye.